Today, my presentation is about progesterone in fresh IVF cycles, a case-based discussion. Suppose you have a young lady who was scheduled for EXE and she was assigned as normal responder. So the long protocol was used, followed by conventional stimulation, and the HCG was used to trigger oocyte. Regarding this case, many questions should be answered. The first is, should this patient receive luteal phase support or not? If yes, which medication is to be used, and what is the best route for administration of this medication, and what is the ideal dose of this drug? And the last two questions that to be answered are when to start and when to stop using the luteal phase support in HCG triggered patient. Regarding the first question, which is, should this patient receive luteal phase support? Yes, there is a general agreement that all women undergoing IVF should receive luteal phase support, and this was attributed to the associated corpus luteum deficiency in these women. Regarding the second question, what is the best drug? Once again, there is a general agreement is that progesterone is the ideal luteal phase support in cycles triggered with HCG. And here we can take a look for this beautiful illustration proposed by Dr. Ziegler. He showed that what's happening if the progesterone is not supplemented in the IVF cycles. Here is the triggering. This is here at the start of this is the HCG. Sorry. Here, this is the triggering dose of HCG. Then the level of HCG in the serum will decrease gradually to disappear after about 1 week. At the same time, this HCG will rescue the corpus luteum, which will start to secrete a relatively low amount of progesterone. The progesterone released by the corpus luteum during that part of the cycle follows the same pattern like that of HCG. That's to say, it's relatively high after HCG injection, then it decreases gradually, and then after about 1 week of HCG injection, both the level of HCG and the progesterone are completely absent in the serum for about 1 week. For 1 week. And this period of time is called the luteal gap, at which there is neither HCG nor progesterone. After the establishment of pregnancy, the HCG from the trophoblast is secreted, which will re-stimulate the corpus luteum again to release progesterone. Just to say that during most of the luteal phase, the progesterone secretion is deficient, so that all IVF women should necessitate progesterone supplementation. Now we are coming to the third question. What is the best route for administration of progesterone? Simply, the best route is the route which provides you with the ideal level. So before answering this question, two issues should be clarified. The first is, what is the optimal serum level of progesterone necessary for implantation? And the second issue, what is the serum level of progesterone obtained after the different routes of administration of the drug? Regarding the first issue, which is the optimal serum level for implantation necessary for implantation. Up till now, really we don't have a sharp cut of values, but this recent study shows that the ideal progesterone level in the early luteal phase should be in the range from 18 to 30 nanogram per milliliter. But in the middle luteal phase, this level it should be higher in a range of 50 to 80 nanogram per milliliter. However, it should be stressed that this minimum threshold or minimum concentration is not absolute, and some centers use a lower or higher level than that reported. But whatever the level you select, it should be higher than the level obtained in natural cycle. That's to say that the progesterone level in the early luteal phase should be more than 6 nanogram per milliliter, and in the middle luteal phase should be at least 25 nanogram per milliliter. About the first issue. Regarding the second issue, which is the serum level of progesterone obtained after the different routes of administration of the drug. Here, this illustration shows the pharmacokinetics of intramuscular progesterone. The 25 milligram intramuscular progesterone would not give you any satisfactory level. The first, about the 50 milligram will give you a satisfactory level of progesterone, which will last for about 12 hours, only 12 hours. However, the only dose which can give you a satisfactory level of progesterone, which lasts for 24 hours, is the 100 milligram 100 milligram injection. This is the highest level. But the most physiologic level of progesterone, again, is achieved with the use of 2 doses of 50 milligram intramuscular progesterone per day. This is regarding the intramuscular. Regarding the subcutaneous progesterone, the subcutaneous progesterone has a very great advantage over the intramuscular, is that it's being very fastly absorbed from the from the injection site when compared to the intramuscular. If we look, the 25 milligram subcutaneous will provide you a satisfactory level for no more than 6 hours. This is regarding the 25. Regarding the 50 milligram of subcutaneous progesterone will provide you a satisfactory level for about 10 hours. The only dose of the subcutaneous progesterone which can cover the whole day with a satisfactory level of progesterone is 100 milligram per day. That's which are equivalent to 4 ampoules of the available drug in Egypt. To be honest, this study has been supported and sponsored by the EFSA company itself. About the vaginal progesterone, the vaginal progesterone has a unique character in that it undergoes a process of first bypass within the endometrium itself. And this will lead to a higher uterine levels or exactly higher endometrial level despite a comparatively low serum level when compared to the intramuscular. The serum level of progesterone after the vaginal route rarely exceeds 35 nanogram per milliliter. This phenomenon have given the vaginal route the name of targeted organ therapy. That it targets the endometrium directly. About the progesterone level after using the dydrogesterone, actually, we don't have any data because the dydrogesterone is rapidly converted to the active metabolite 20-alpha dihydrogesterone. Okay, this is about the pharmacokinetics. What about the clinical evidence? The clinical evidence states that the oral dydrogesterone, intramuscular, vaginal, and subcutaneous progesterones all have comparable live birth and miscarriage rate. This is the last evidence, including the last IFRE guidelines in 2019. But this question, which is the best route, is still not closed. It's still open. We will close only after asking ourselves again, is really oral dydrogesterone would provide with a sufficient luteal phase support? If we look for the basic science, which is the root from which the applied science is originated, the basic science indicates that or reported that oral dydrogesterone does not induce adequate secretory change. Moreover, or in addition to that, in one study shows that the oral dydrogesterone induced out of phase endometrium in more than 80% of the patients. This is on one side, but on the other side of the beach, the clinical trials yielded a very different results. And many studies which have been conducted in respectable institutions and supported by famous researchers stated that the vaginal or intramuscular progesterone confers no advantage over the oral dydrogesterone. And according to that, The EFRE has no way and should respond to these respectable studies and should include these studies within its last guidelines, which decided that oral dydrogesterone is probably recommended for luteal phase support, and please put more than 100 lines below the word probably. And after that, many things that regarding the oral dydrogesterone as a luteal phase support, it is a lifeless drug because it's instituted and commercialized through a process of persuasion. And persuasion means convincing the others when the facts don't seem to be manner. And this has been reflected in the field or in the clinical practice, where the IVF survey in 2018, which is the largest survey up till now, showed that less than 0.5 of all IVF centers all over the world and throughout the different 6 continents use oral dydrogesterone in comparison, for example, to 60 to 76 of the IVF cycles use vaginal progesterone. Now, we should close this question is which route you can either use the vaginal or the intramuscular route. If you select to use the vaginal route, you should ask ourselves, what is the best vaginal preparation? All of us know that there are many vaginal preparations available, including tablets, capsules, gels, and suppository. The clinical evidence states that all have a similar clinical pregnancy rate. But a recent study shows that the micronized capsule has a more steady concentration of progesterone and is associated with a less bleeding episodes compared to others. And this may be attributed to the relatively slower rate of absorption of progesterone from the capsule when it is compared, for example, to the gel, which it dissolves rapidly, or to the suppository. Regarding the most frequently used formula all over the world, about half of the IVF centers all over the world will use the micronized progesterone capsule. The fourth drug, what is the optimal dosage of progesterone necessary for luteal phase support? This table will summarize the ideal or the most frequently doses of progesterone used for luteal phase support. But after looking for this anybody may ask herself, is increasing the dose of progesterone is beneficial or not? For example, instead of giving 600 milligrams per day progesterone, why not giving 1,000 or 1,200 or so on? The answer about this question, although the ceiling concentration of progesterone is not well delineated, but again, this study shows that if the progesterone in the early luteal phase was more than 30 or more than 80 in the middle luteal phase, this will decrease the pregnancy rate considerably, and which has been supported by another experimental study which reported that the high concentration of progesterone is harmful both for endometrial receptivity and for destabilization. So we should close this question. We should give the patient the ideal dose. About the fifth question, when to start using progesterone? Your main goal is to induce what's called endometrial embryo synchronization. That's to say, it's not preferable to start the progesterone early, so that causing early closure of the implantation window, and not to delay it more, causing failure of implantation. And many days have been proposed, but the last EFRE guidelines state that you can give the progesterone at the day of oocyte pickup or 3 days later. However, a more recent meta-analysis found that the highest pregnancy rate was reported if the progesterone was used at 1 day after the oocyte pickup, and the delaying progesterone more than that will cause a decrease in the pregnancy rate. And another very interesting finding in this study with using an intramuscular progesterone, the pregnancy high if it is used on the day of oocyte pickup, while the vaginal progesterone was associated with a higher pregnancy rate if the vaginal progesterone was introduced 1 day after the oocyte retrieval. In conclusion, we should close this question. You can start progesterone supplementation ideally 1 day after the oocyte retrieval, but if you want to use the intramuscular progesterone, it is preferable to use it at the day of oocyte pickup. And here is the IVF World Survey. About half of the center use it on the day of oocyte pickup. Now we are coming to the last question and the most debatable question: when to stop using the progesterone. Many points and times have been proposed. Let us to agree that nature is the ever best teacher. I think all of us agree about that. What nature states about progesterone both during the luteal phase and during the early weeks of pregnancy is that the progesterone is kept in a spectacular state of idealistic homokinetic. And looking to this very nice figure, what's happening to the progesterone during the first 12 weeks? During most of these weeks, the progesterone level is not higher than the middle luteal phase. Not only that, during the first 6 to 8 weeks of pregnancy, the progesterone level decreases to reach a lower level at about 8 weeks of about 10 nanogram per milliliter. And by the end of the first trimester, at 12 weeks of pregnancy, the maximal serum concentration of progesterone during pregnancy rarely exceeds 40 nanogram per milliliter. This is here regarding the physiology, taking into account that the native HCG is more potent and has a different isoform when compared to the commercialized urinary HCG. According to that, if the body would need additional progesterone, it's very easy. It can very easy and competently output it. But the body does not need extra amount of progesterone. It needs this amount which are ultra titrated of progesterone. According to this background, the evidence states that, including a recent meta-analysis in this year, published in this year, is that progesterone supplementation after the first positive pregnancy test is unnecessary. And about 10 years ago, Professor Gresinger of Deutschland put an inquiry: is it the time to abandon the progesterone supplementation during the early pregnancy after IVF? All of us know that the area of IVF has many pressures, including patient pressure, social pressure, financial pressure. So regarding this point, regarding the stoppage of progesterone, we should reach a compromise between these pressures and the scientific evidence. And this compromise has been described again by a German researcher, which is Professor Klaus Dietrich. This was about 20 years, more than about 20 years ago, when he stated that it's better to stop progesterone supplementation just 3 weeks after embryo transfer. That means that 1 week after a first positive pregnancy test. And why during that time in particular? Because during that time, the effect of GnRH agonist is completely ablated, and during that time, the HCG originated by the trophoblast will dominate. So we should close this question: the time of stoppage of progesterone either at the time of positive pregnancy test or just 1 week later. About the survey, what is the result of the survey? The time to stop progesterone. Unfortunately, 1/3 of the centers all over the world continue progesterone to 10 weeks of pregnancy, the other third to 12 weeks of pregnancy, and only 14% of the IVF centers will stop it at the time of a positive pregnancy test. The attitude of the gynecologist regarding the time of stoppage of progesterone didn't change throughout the 10 years, from the old survey in 2009 to the recent survey in 2018. If we have compared the different IVF centers in the different 6 continents about their attitude, in Africa, 100% of the centers use progesterone till 10 to 12 weeks of pregnancy. In Europe, about half of the centers contain progesterone for up to 10 weeks of pregnancy. About the IVF center regarding when the time of a stoppage of progesterone at the time of a positive pregnancy test in Africa and South America, none of the IVF centers have this policy, and the highest rate again was found in Europe, where just about less than 1/4 of the IVF centers in Europe discontinue progesterone at the time of a positive pregnancy test. And now come the last question: why regarding this area in particular is the evidence-based medicine is not translated into clinical practice? And the reason has been attributed by Professor Douglas in 2015 to be due to non-medical reasons, that the gynecologist follow the policy of better safe than sorry. That he want to stand on the safe side and continue progesterone until advanced stage of pregnancy, and even the pregnancy didn't continue, he will say for the patient, I did everything. And instead of saying sorry for the patient, in this time I have disconnected progesterone early, but in the next pregnancy it's better to continue early, to a late stage. This is the policy of better safe than sorry. And another argument is there is lack of confidence in implementing the guidelines of the best available evidence by many researchers. And as Professor Ever stated, that regarding the gynecologist, yes, the gynecologist know the evidence, but he says, I know, but I don't care. And I'm always closing up by my presentation with this immortal statement: is knowledge looks like an endless puzzle. The more picture you put, the more new question you get. And many thanks for all of you.